Welcome to the deep dive. You know, when you think of a laser, the immediate image is usually like science fiction, or at least industrial manufacturing.
Right. You picture absolute pinpoint precision.
Exactly. A beam of light so exact it can cut through a sheet of steel or, a line satellite hardware. There is this expectation of total clinical control where input A directly guarantees output B.
Because in those environments, it essentially is just a mathematical equation. It's perfectly sterile, completely predictable physics.
But then you take that exact same technology, this immensely powerful concentrated beam of light, and you point it at human skin.
And suddenly that math collides with biology.
Right. We're not looking at a clean equation anymore. We are looking at what is essentially a chaotic biological wildfire. You are intentionally initiating a massive trauma and relying entirely on the body's chaotic immune system to put the pieces back together.
It is the absolute definition of controlled biological trauma. I mean, it is messy, it's intensely complicated from a physiological standpoint, and yet it is precisely that biological chaos that generates the results people want.
Which is exactly our mission today. We want to shortcut your path to being incredibly well-informed about what actually happens when high-powered lasers meet human skin.
And, of course, how the UK is currently scrambling to regulate a rapidly exploding industry.
Oh, absolutely. We have a massive stack of sources for you today. We're pulling from clinical guides from the London Medical and Aesthetic Clinic, the Cleveland Clinic, and patient info from the North Bristol NHS Trust.
We also have research from the Institute of Medical Physics, insights from Dr. Human Khorasani, ethical guidance from the MDU Journal, and a very detailed UK government consultation response regarding new licensing schemes.
It is a lot of ground to cover. Okay, let's unpack this. Before we can even understand the regulations or the different machines, we first need to understand the underlying biology. Like, what is a laser actually doing to your face?
Well, it's definitely not just painting on a new layer of skin. If we look at the CO2 laser, which the clinical data routinely calls the gold standard for deep resurfacing, we're looking at a highly targeted form of tissue destruction.
Tissue destruction, that sounds intense.
It is. A CO2 laser uses a concentrated beam of light, but it's calibrated to a specific wavelength that doesn't just blast the skin blindly, it specifically targets the water within the skin cells.
Because human cells are essentially just tiny balloons filled with water, right?
Precisely. The laser energy is absorbed by that water so rapidly that the water reaches its boiling point in a fraction of a millisecond.
Oh, wow.
Yeah. The targeted cells essentially vaporize. They undergo immediate thermal ablation, turning instantly into a plume of smoke and gas.
So you are instantaneously deleting tiny layers of damaged tissue. But the real magic isn't the vaporization itself, is it?
No, not at all. It's the chain reaction that the vaporization triggers in the deeper layers that are left behind. The body registers that sudden, massive thermal injury and just goes into emergency systemic repair.
Which the London Medical and Aesthetic Clinic breaks down into a complex biological cycle.
Right. They map out 3 distinct phases of healing. And this timeline is crucial because it really shatters the illusion that a laser treatment is just a quick weekend fix.
So what's phase 1?
The first phase is the regeneration phase, which spans the first 1 to 8 weeks.
And that is entirely focused on surface survival, right? Like reestablishing the barrier.
Yes, exactly. The immediate priority is protecting the internal systems from infection. Macrophages rush in to clear the debris, and the body initiates a massive inflammatory response.
So that's the intense redness and swelling you see.
Right. The tissue is desperately trying to seal the wound. Then, once that barrier is reestablished, the inflammation subsides, and you move into the collagen production phase.
Which they say stretches from month 1 all the way to month 6.
Yeah. The thermal stress forces the fibroblast cells into absolute overdrive. They begin synthesizing massive quantities of new collagen to replace what was lost. But this new collagen is laid down pretty rapidly and somewhat haphazardly.
Which leads into the final stretch, the collagen maturation phase, from month 6 to a full 12 months post-treatment.
Exactly. Those collagen fibers slowly reorganize, cross-link, and tighten. So you don't actually see the full final result of the procedure until an entire year later.
So it's essentially like a controlled forest fire. You're intentionally burning away the dead wood on the surface so that a much healthier, stronger ecosystem can grow back underneath.
That analogy perfectly dismantles one of the most persistent myths out there. There's this common assumption that if you are repeatedly vaporizing layers of skin, it must eventually become paper thin.
Yeah, I mean, logically, if you keep sanding down a piece of wood, eventually you run out of wood.
But skin isn't wood. What's fascinating here is that because of that massive collagen synthesis response you just described, because that stronger ecosystem is actively growing from the bottom up, repeating CO2 lasers correctly doesn't thin the skin at all.
Wait, really?
Yeah. Done properly, stacking those layers of new collagen actually increases the dermal thickness. The skin becomes firmer and structurally stronger over time.
That is wild. Okay, but since the body takes up to a year to fully mature a new collagen, how does that dictate when you should actually get a treatment? Especially if you were trying to fix something specific, like a surgical scar.
That is a great question. The London Skin Clinic provides a very clear timeline for surgical scars. The first week post-surgery is the inflammatory phase. It's red, tender, swollen.
Right.
Then, weeks 2 to 8 is the proliferative phase. That's when the body is churning out that haphazard collagen, creating raised textures. Finally, from 2 months up to 2 years, you have the maturation phase, where that collagen breaks down and reorganizes.
Wait, if the body is producing all that chaotic raised collagen in the first few weeks, wouldn't you want to hit it with the laser immediately to stop the scar from setting?
You'd think so, but no.
Yeah.
The clinical consensus is that lasering too early actually worsens the inflammation. It creates a much worse scar.
Oh, because it's already inflamed.
Exactly. You are adding extreme thermal trauma to a system that is already panicking. You have to wait for what they call the Goldilocks window.
The Goldilocks window. I like that. When is that?
It's early to mid-maturation, usually 6 to 8 weeks, up to 3 to 6 months post-surgery. You have to work with the body's natural cycle, not against it.
And that biological pacing matters for repeat full-face treatments too, right?
Heavily. Deep ablative treatments need to be spaced 1 to 5 years apart.
Wow, up to 5 years.
Yeah, but lighter fractional treatments can be done 4 to 6 weeks apart. But you have to be careful. The North Bristol NHS Trust and the Cleveland Clinic explicitly warn about doing it too soon.
What happens if you do?
You risk prolonged inflammation, milia, which are those little white bumps, reactivation of cold sores, and permanent pigmentation changes.
The pigmentation issue is huge,
Yeah.
especially for darker skin tones.
Yes, the Fitzpatrick scale is crucial here. Types 4 through 6, which represent darker skin tones, face severe risks of hyperpigmentation. The pigment-producing cells basically mount an aggressive defense against the heat.
So they just flood the tissue with dark pigment.
Exactly. And is notoriously difficult to reverse. Also, patients currently on blood thinners like warfarin, or who recently used the acne medication Roaccutane, are strictly warned against these procedures due to compromised healing.
Okay, so knowing that a heavyweight ablative laser demands intense medical aftercare and carries serious risks, it makes sense why not everyone wants or needs the most aggressive treatment.
Right. How do you choose the right weapon for the job?
Well, Dr. Human Khorasani breaks down the technology into 3 distinct tiers, which I found really helpful.
It's a great framework.
At the bottom, you have the entry-level tier, things like the Clear plus Brilliant machine. He calls this the starter laser. It's superficial, literally no downtime, and gives you a great pre-event glow. It's basically the grandchild of the CO2 laser.
Then you move to the middle ground. Machines like the Fraxel 1927 nanometer.
And this is non-ablative, right?
Correct. It doesn't vaporize the top layer. It passes through the surface and only converts to heat in the deeper tissue. So it tackles pigmentation and fine lines with manageable downtime. You're just peeling for a few days.
And then at the top, the heavyweight. Fractional CO2 lasers, like the luminous ultrapulse. This removes entire layers of skin for deep wrinkles and severe acne scars.
That's the heavy hitter.
But I have to ask, if the fractional CO2 laser is the absolute gold standard for dramatic results, why would anyone waste time and money on the weaker lasers? Why not just go straight for the heavyweight?
It comes down to the trade-offs. The Institute of Medical Physics data breaks this down well. A deep ablative CO2 laser requires up to 2 to 4 weeks of intense downtime. You literally have to hide from the sun.
Right, you're basically an open wound.
Yeah. Plus, different goals require different session counts. Treating deep acne scars might take 5 to 7 sessions. Pigmentation might only take 3 to 4. Not everyone can afford to take a month off work for physical downtime.
That makes total sense.
And if we connect this to the bigger picture, you have to look at how fractional technology revolutionized the field. Older, fully ablative lasers used to strip the entire surface area. The downtime was immense.
But fractional splits it up.
Exactly. It splits the beam into microscopic columns, vaporizing tiny dots of skin while leaving the healthy tissue around it totally intact. That healthy tissue speeds up the recovery drastically compared to the old methods.
So you get the deep trauma without the month-long recovery. Okay, so these heavyweight machines are vaporizing human tissue and requiring immense medical aftercare, which brings us to a huge question.
Who is actually allowed to operate them?
Right, and this leads us to the shocking reality of the current regulatory landscape. The UK government's recent consultation response paints a picture of a really fragmented, under-regulated Wild West.
It really is. The industry is exploding based on huge demand and social media pressure, but the rules haven't kept up.
And there are tragic consequences. The death of Alice Webb from a non-surgical Brazilian butt lift really spurred intense calls for Alice's Law.
Her case was a massive catalyst. It highlighted how dangerous it is when people without proper medical emergency training are performing high-risk procedures.
So in response, the government proposed a three-tier regulatory system.
Right. They categorized it by risk. First is the green tier, which is the lowest risk. This includes things like cosmetic piercing. All practitioners would be eligible to perform these as long as they meet basic hygiene standards.
Then there's the amber tier.
The medium risk. This would require oversight by a named, regulated healthcare professional.
And finally, the red tier, highest risk. The proposal is to bring this entirely under Care Quality Commission, or CQC, regulation. It would be restricted only to qualified healthcare professionals. Here's where it gets really interesting. Because the consultation responses show a fierce, highly polarized debate over who gets to do the amber and red tier procedures.
It is intensely debated.
And we really want to just impartially lay out both sides here without taking one because it's a complicated issue. So side A is the regulated healthcare professionals, the doctors and prescribing nurses.
Their argument is that aesthetic procedures are inherently clinical.
Right. They say only medical professionals understand anatomy well enough to handle severe complications. Things like vascular occlusion, where a filler accidentally blocks an artery.
Yeah, if you don't recognize that instantly, it can lead to tissue death or blindness. And they point out that only medical prescribers can legally give the emergency medicine, like hyaluronidase, to dissolve the blockage.
But then you have side B, experienced aesthetic practitioners who argue against that.
They point out that medical professionals aren't routinely trained in aesthetics in standard medical school.
Exactly. They argue that a non-medic who has extensive, specific cosmetic training is just as qualified. They feel that restricting procedures based on a professional title rather than specific training standards is just going to destroy legitimate businesses.
It's a clash over what actually guarantees safety, a general medical degree, or specialized technical training.
And for the medical professionals, there's also the ethical burden. The MDU Journal details strict guidance from the General Medical Council for doctors doing these procedures.
The GMC rules are very strict. For one, doctors absolutely cannot delegate consent.
Meaning a receptionist can't just hand you a form to sign.
Right. The doctor has to personally ask the patient why they want the procedure to screen for psychological issues. They're also completely banned from using promotional tactics or offering treatments as prizes to induce quick decisions.
No more Instagram giveaways for laser resurfacing.
Definitely not. And furthermore, treating anyone under 18 is strictly banned unless it is medically approved by a doctor, like for severe acne scarring.
So pulling all of this together, if you are listening to this and ever considering taking the plunge into skin resurfacing, you now understand that you aren't just buying a quick fix.
You are investing in a year-long biological process.
Exactly. You now know to ask about the specific machine being used. You know to ask about your Fitzpatrick skin type and the exact qualifications of the person holding that laser.
This raises an important question, though.
Oh, what's that?
Well, looking at the sheer pace of this technology, these lasers are becoming increasingly microscopic, highly precise, and capable of manipulating our very collagen structures.
Yeah, the innovation is relentless.
So, are we approaching a future where cosmetic procedures are no longer viewed as vanity enhancements, but rather as routine, preventative medical maintenance?
Like going to the dentist.
Exactly. Will the concept of aging naturally soon be considered a deliberate medical choice rather than just an inevitability?
Wow. That is a wild thought to end on. A deliberate medical choice. Well, we want to thank you for joining us on this deep dive into the source material.
It's been a fascinating one.
It really has. We'll catch you on the next deep dive.